Hello, I'm Dr. Phil Boisel, Director of Thoracic Imaging at Beth Israel Deaconess Medical Center.
Hi, I'm Dr. Eddie Lee from Boston Children's Hospital.
We're here today at Children's Hospital in Boston to talk with you about tracheobronchomalacia, a condition characterized by excessive expiratory collapse of the airways. It's interesting. Tracheobronchomalacia is the most common congenital anomaly of the airways and a common cause of respiratory symptoms, but yet it frequently goes either misdiagnosed as asthma or completely undiagnosed at all.
That is so true, and today we'll show you how we can perform multi-detector CT for evaluating tracheobronchomalacia in children. Let's first start by reviewing common symptoms and clinical indications.
Clinical symptoms associated with tracheobronchomalacia in infants and children are typically nonspecific. The most common symptoms include expiratory stridor, an expiratory cough that is often barking or brassy, and recurrent lower airways infections. Although precise indications are evolving and established clinical guidelines are not yet available, an evaluation for tracheobronchomalacia is generally indicated for therapy-resistant, irreversible, and/or atypical asthma, as well as for unexplained impaired exercise tolerance, recurrent lower airways infection, and paratracheal mediastinal vascular anomalies associated with respiratory distress.
I would like to introduce you to a multi-detector CT protocol for evaluating children with possible tracheobronchomalacia.
Evaluation of tracheobronchomalacia requires that the patient be imaged during both the inspiratory and expiratory phases of the respiratory cycle. In general, in children 5 years of age or older who can follow breathing directions, inspiratory and expiratory CT can be obtained without sedation after practicing breathing techniques. In contrast, infants and children less than 5 years of age usually require general anesthesia and intubation in order to apply a controlled ventilation technique for inspiratory and expiratory phases of CT imaging. Because infants and children are more susceptible to the potentially harmful effects of ionizing radiation than adults, it is important to always use weight-based low-dose CT techniques. In order to further decrease the radiation dose, the MAS should be reduced by another 50% during the expiratory phase of CT. Thin collimation and fast table speed are also important CT parameters for evaluating tracheobronchomalacia. Now, intravenous contrast material is not necessary for the routine assessment of tracheobronchomalacia. However, it should be considered in children with suspected mediastinal vascular anomalies and those with extrinsic mediastinal masses. When performing CT, the end inspiratory phase is performed first, followed by the expiratory phase, and both sequences are performed from the cranial to caudal direction.
Next, Nancy Shatola, pulmonary technologist, will demonstrate how to practice breathing instructions for the study. We have found that our CT technologists can also effectively practice breathing instructions with our patients after a short training session.
Hey Rachel, how you doing?
Good.
Good. Okay, so we're going to practice what we're going to do in the other room, okay? So the first thing I want you to do is put your hands up here like this. Good, just like that. Excellent. Then we're going to take some nice big breaths, okay? And I'm going to ask you to hold your breath for about 5 to 7 seconds, okay? Take a nice big breath for me, all the way up, 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 and hold it. Hold it, hold it, hold it, hold it, hold it, hold it, and breathe. Good job. Let's try it the other way now, okay? Take a nice big breath in and blow it all the way to the bottom when I tell you to, okay? Nice big breath all the way up, 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 and blow it out to the bottom, all the way, all the way, all the way, all the way. Good. Hold it, 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 and breathe. Good job. Very good. Okay, Rachel, you ready? Big breath in. Good. Big breath in. Hold it, 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 hold it. Breathe out. Good. All right, you ready? Let's take a nice big breath in, all the way up, 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 and blow it out to the bottom. All the way out, all the way out. Push, push, push. Good. Hold it, 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 and breathe. Good job.
In assessing for tracheobronchomalacia, Inspiratory and expiratory axial CT images must be carefully evaluated and compared at similar anatomic levels. Although the tracheal lumen can be accurately assessed on axial CT images, the obliquely oriented main bronchi are more accurately assessed using curved multiplanar volume reformations or 3D reconstructions. After checking the quality of end inspiratory and end expiratory phase CT images, the degree of tracheobronchial collapse can be evaluated by measuring the luminal area of the airways at inspiration and expiration. When there is near complete or total expiratory collapse, the diagnosis may be made visually without the need for quantitative measurements. The standard CT criterion of at least 50% expiratory reduction in the cross-sectional area of the central airways is applied for diagnosing tracheobronchomalacia. However, it is important to be aware of the potential for false positive diagnoses at the low range of positivity.
In summary, we have reviewed a practical protocol for diagnosing tracheobronchomalacia using multi-detector CT in children. 3 important considerations include: first, attention to low-dose technique; second, breathing instructions; and third, measurement methods. We hope that you will find this information helpful for implementing this protocol in your practice. We encourage you to read our How I Do It article in Radiology to learn further information about this technique. Thank you.